So I'll be talking about intracorneal ring segments and cross-linking. So whether they should be done simultaneously or whether they should be done sequentially. So now this has been, I hope my screen is shared and yeah. So this has been a long-ranging debate. So there's nothing new in this particular debate. Now I'm just weighing the pros and cons of each and what the studies say and what has been seen over the years. So now by simultaneously, we know it happens during the same sitting. That is, you implant the intracorneal ring segment, and this is followed by the collagen cross-linking, which can be accelerated or may follow the full Dresden protocol, or it may be an epithelium on cross-linking or an epithelium off cross-linking. Sequential means you do the intracorneal ring segments first and then wait for some time, usually at least 3 months before you do the second procedure of collagen cross-linking. Or there are people who actually do the cross-linking first and then may follow it up with ICRS. So the theory behind this is that ICRS basically flattens the corneal surface, and therefore it betters the shape of the cornea and increases the visual acuity, decreases the keratometry reading, but does nothing for the pathology underneath, which is what is handled by the CXL. So to stabilize the cornea, you need the CXL part of it. And it has been postulated that when these two are combined, the effects are potentiated. So when do you use this particular technique? As we know, we can have CXL alone, you can have ICRS alone, you can have CXL combined with topo-guided PRK, and of course CXL combined with ICRS. So it is recommended that CXL combined with ICRS is used when the corrected distance visual acuity is on the worst side. So if you have a sort of irregular cornea which you just want to smoothen off with the topographer, then the topo-guided PRK is what you would choose over the ICRS. But when you have to flatten the cornea a lot, you have a highly decentered cone that you want to bring to the center and add some tissue to the cornea, then it is the ICRS along with CXL that is used. So the basic rules of planning for this procedure is all the same as that for any general ICRS. You have myopic correction with symmetrical segments, and when a high astigmatic component is there, you use asymmetrical segments, and for oval cones, you can have a single inferior segment. And as Dr. Reddy has already shown, the effects are drastic, just like with CXL. You can see how here the astigmatism has been grossly reduced. The K values have been transformed from what was in the range of 4952 to 4447. So this improves the visual acuity, as you can see, from a best corrected of 624 parts to 6.6, and how the astigmatism and the spherical equivalent has grossly reduced. So this is how the eye looks after the procedure on the anterior and under the slit lamp. Now, the debate is whether when you do a simultaneous ICRS and cross-linking, do you keep the epithelium on or take it off? Now, there advocates for both, because when you keep the epithelium on and you do an accelerated version of the cross-linking, the healing is faster. So that is one of the basic things for which you do a simultaneous ICRS with CXL, so that you don't need to wait for a long period in these young people who have a lot of work to do and need to get back to their routine. So accelerated epithelium on cross-linking is advocated by a lot, but as we know, and as Dr. Rajesh had pointed out, that the effects of transepithelial cross-linking is not quite as good as epithelium off. The advocates of epithelium off swear by it, and they are willing to take the epithelium off on a freshly implanted ICRS to do the cross-linking. So by any of these methods, approximately 5 diopters of reduction in keratometry readings are seen. Now, those with epithelium on have found that in some of the cases, at least 1/3 of the cases in this study progressed. The keratoconus progressed and then later required an epithelium of CXL. So I think that speaks a lot for having an epithelium of CXL in the beginning itself. Now, the second question is that suppose you're doing a sequential. Now, which order comes first? Should you do the C3R first, or should you do the corneal ring segments first? Now, it has been said that though CXL deals with the pathology of the cornea, and that is perhaps the primary step in treatment of keratoconus, and ICRS is a supplement to flatten the extremely steep cornea, it has been known and multiple studies have shown that the implantation of a corneal ring segment into an intact cornea has a greater effect, much greater flattening effect than an already cross-linked stiff cornea. So that is what is advocated, that ICRS be done first, and then you wait for some time before you do the CXL in a sequential cornea. And the effect of CXL is also thus potentiated by the already flattened cornea that has been created by the ICRS. So again, here the change in keratometry is in the range of 4 to 5 diopters. And now these were some of the issues that were plaguing the two types of sequential or the simultaneous procedures. Now this is a study which compared simultaneous and sequential ICRS with CXL. And here they included 19 eyes in the simultaneous category and 7 in the sequential. The ICRS used was intact and they followed the full resident protocol. Now, let me tell you that none of the studies, whether it is this one or another one that I'm going to show, had any statistically significant difference between groups. So I just picked out the clinical results and this is what it showed. So here you can see the logMAR change in the corrected and uncorrected visual acuities and the reduction in the Kmax, K average, and the change in the inferior superior asymmetry. And as you go by the numbers, you can see that it's the sequential ICRS plus CXL that seems to have a higher effect on the keratometry value, better effect on vision, and on the asymmetry between the inferior and superior cornea. So now this is another study which had 3 groups. One was simultaneous ICRS CXL, the other was a sequential CXL ICRS, and the third was ICRS alone. Again, in this group, you can see here that there was no statistically significant differences between these groups. Again, I looked up the clinical data here. But there's one more thing that they have mentioned, that in the group that underwent a sequential procedure, they had seen an improvement in both the corrected and the uncorrected visual acuity in all the patients. So it was not just an average, in all the patients it was seen. Now going to the clinical data in this group, it was seen that it is the simultaneous, that is the single procedure ICRS CXL that happened to produce a far greater benefit. Here you can see that the keratometry value, if it decreased by 6 diopters in the simultaneous group, it decreased only by 4 in the other group. So now these are such are the results of various studies, some that favor simultaneously and some that favor sequential, but uniformly all of them mention that none of these are statistically significant, but though we can see the results. I'll be just taking a couple of seconds. So you can see here there is an ICRS happening. So these are through the femto pockets created by the FS200. And so here the cone was central and there was a steep central cornea, more of myopia than astigmatism, because of which we have symmetrical ring segments going on either side about the steep axis of astigmatism. So ultimately this is sutured where at the pocket so that there is no extrusion of the rings. Now this is followed by the CXL procedure. So here you can see that this is an epithelium on procedure, and so that is the video of the procedure basically. Now finally, when you do a simultaneous treatment, it's basically the recovery time that is saved upon, and though the protocols vary, it has been shown that this may be useful in working age group patients when the sitting is simultaneous, whereas in sequential, there may be a more of mechanical flattening of the cornea potentiated by one procedure over the other. So the result is that debate still rages on and there is no definite conclusion. Thank you very much.